Wait, 1 minute.
Okay.
Just recording.
Okay.
Wait, 1 minute. You can start now.
Good morning, everyone. Welcome to our presentation today about UAC and UVC guidelines in Saudi German Hospital, Ajman in ICU. As we know, umbilical cord.
Marwa, just press on presentation. So make it your PowerPoint presentation. Down, down if you go beside the, down, beside the bar for the sound.
Where?
Down beside the bar, more to the right, more to the right, more to the right, on the other side. Yeah, more. No.
Here,
beside the sound, just beside the sound bar. Yes, beside the sound bar. There is an icon, you press on it. No, in the window, in the PowerPoint, Go back to the PowerPoint.
Okay.
Go back to the PowerPoint. Just press on the PowerPoint. Press anywhere, yes. Go to the sound. You see the sound?
Yes.
Beside it, there is an icon. Press on it. Do you see the sound bar? There is a plus, there is minus. Beside the minus sign, there is another sign. Yes, this one. Press. Okay, go ahead.
Umbilical cord is consisted of 2 umbilical arteries and 1 umbilical vein. Our guidelines purpose to provide standard practice for physician and nurse during placement and removal of umbilical catheters. Indication for UAC replacement, need for frequent or continuous measurement of PaO2 or oxygen content, continuous monitoring of arterial blood pressure, and need for continuous vasopressor exchange transfusion. Indications for UVC placement, need for emergent administration of medications or intravenous fluid during resuscitation, inadequate
so this
vascular
one, Marwa, in this one, it's they call it urgent, and usually it's aseptic technique, and usually it's in the resusc room. Okay, go ahead.
Okay. Inadequate vascular access, neonates weighing less than 1,500 grams for parenteral nutrition immediately after birth. Therapeutic hypothermia, need for total parenteral nutrition, dextrose concentrations greater than 12.5%, continuous vasopressor or continuous analgesia for sedation.
Yeah, Marwa, for this one, the dextrose concentration
unless
12.5
is more appropriate.
Yeah, 12.5% usually you can give it for 1 day or maybe 2 days using peripheral. But if you need 12.5, more than 2 days or more than 12.5,
we will need
to switch to the UVC. Yeah, go ahead.
Need for prolonged IV antibiotic therapy unless PIC is more appropriate. Need for exchange transfusion. Neonates with GI, congenital or cardiac disorders, as indicated by clinical condition, with exception of GI contraindication listed below. Contraindication of UAC or UVC placement: omphalitis, omphalocele, necrotizing enterocolitis, peritonitis, acute abdominal pathology. Potential complication of UAC placement: catheter malposition, vessel or peritoneal perforation.
Yeah, so in this one,
vascular accident,
this is the most common. Okay.
Okay.
So you can perforate the vessels because bleeding, or you can perforate the peritoneum, and also the catheter you place, but it moves somewhere else. This is the most common. Yeah, go ahead.
And vascular accident like thrombosis, embolism, infarction, vasospasm.
The vasospasm usually present with changing colors in the lower limb or lower abdomen. You know, it looks like a valid, pale, and sometimes plunchy area, like white color, usually occur. And also you can have vasomotor instability, you know, one lower limb different from other, or some skin changes in the lower abdomen. Yeah, go ahead.
Hypertension, air embolism, infection. Per CDC recommendations, UAC should be kept in no longer than 5 days. And bleeding. Potential complication of UVC placement, catheter malposition in the heart or liver, infection. Per CDC,
so when the UVC become in the liver and you infuse dextrose, it's not a big deal. But if you're infusing electrolytes, TPN, medication, inotrope, you can damage the liver, you can cause necrosis. So it's very important to know that. It's always better to avoid, and therefore the UVC should be always at the level of the diaphragm and away from the liver. If it's in the heart, it can cause movement and turbulence of flow and can cause thrombosis and also may cause arrhythmia. Yeah, go ahead.
UVC should be kept in no longer than 14 days, but ideally removed by 7 to 10 days.
Some articles say up to 28 days, but I usually, in my practice, once I reach 10 days, at day 11, I would say, do I need it really? Can I survive with peripheral IV? Can I insert a PICC line? And so on. Yeah, go ahead.
Vessel or peritoneal perforation, bleeding, thromboembolism, cardiac arrhythmia. Opening. Umbilical catheterization tray includes umbilical cap, antiseptic solution, forceps, scalpel, and 3 silk suture on a small curved needle. Chlorhexidine if using for skin cleansing.
Yeah, so usually we don't use chlorhexidine for babies below 1,500 grams. So we need to be careful because you can burn the skin. Yeah, go ahead.
Umbilical catheter, 3.5 French or 5 French, single or double lumen, 2.5 French. Single lumen.
So 2.5
straps, gown, gloves, powder.
Dr. Marwa, the single lumen with 2.5, they are together. Go ahead.
Okay. Hat and mask. Needleless IV port adapter sleeves, T-connector for arterial catheter, and 1 port for venous catheter to connect.
Yes, 3-way stopcock for the UAC and 3-way T connector or single T connector for the UVC.
Heparinite saline, have normal saline with heparin, 0.5 unit per ml. Syringes, 1, 3, and 5 ml, and or 1 ml heparinized blood gas syringe, enough to flush each lumen of catheter and draw blood for labs. Here is the equipment. Measurement and positioning of umbilical catheter. 4 umbilical venous catheter, double lumen, 3.5 French catheters are generally used in infants weighing less than 1.5 kg, and 5 French catheters in infants weighing more than or equal to 1.5 kg.
Okay.
For umbilical arterial catheter, 2.5 French catheters are generally used in infants weighing less than 1 kg, and 3.5 French is in infants weighing more than 1 kg. An umbilical arterial catheter is in correct position between thoracic vertebrae 6 and 9. A shorthand formula can be used to estimate the total catheter length. The umbilical arterial catheter length in centimeters can be calculated from particular formula 3 multiplied by the birth weight in kg plus 9. Alternatively, measure the distance from the umbilicus to the acromyoclavicular joint of the shoulder. An umbilical venous catheter is in correct position at the level of the diaphragm. The umbilical venous catheter length in centimeters is calculated from Shackler's formula as half of 3 multiplied by the birth weight in kg plus 9.
So half the arterial.
Yes, plus 1 centimeter for the stump. Alternatively, measure the distance from the umbilicus to the xiphoid and add 1 centimeter to account for the length of the umbilical stump remaining. Central UVC confirmed by X-ray in the inferior vena cava at the level of the diaphragm and below the heart. Low-lying UVCs that cannot be advanced beyond the liver and are not considered central are used peripherally. Only peripheral concentration of drugs and solution are used. A low-lying UVC may be placed for volume resuscitation or medication administration during emergency situations in the delivery room. The UVC is non-sterile and must be replaced centrally. For umbilical venous catheter,
so a UVC inserted in the labor room to do the everything should be removed and replaced because it's non-sterile. It can cause infections. Let's be replaced in the NICU. Yes. Yeah, go ahead.
For umbilical venous catheter, double lumen 3.5 French catheters are generally used in infants weighing less than 1.5 kg and 5 French catheters in infant weighing more than or equal to 1.5 kg. Physician task. Determination of need of is assessed by medical team. Gather all equipment and supplies for the sterile procedure. As we told in section, it determines the size and type of catheter needed based on infant size, needs, and acuity. Clean work service to be used with aseptic wipes and allowed to dry completely prior to set up. Perform hand hygiene with a waterless alcohol hand rub. Put on hat and mask. Open equipment and drop sterile items on sterile field. Open sterile gown and gloves. Position the infant appropriately for the procedure, supine with extremities appropriately secured. Do 3 minutes scrub with chlorhexidine, then dry and do sterile gown and gloves. Place a needleless connector on the end of the UVC blue cord. Place a T-connector followed by a needleless connector to the end of the clear port of the UVC, and to the UAC catheter to be used with hemi-closed blood draw system. Hand wash and gown and mask and preparing the catheter and the equipment. Here how you are connecting and flushing. Physician task. Draw up half normal saline with 0.5 units per ml of heparin in a sterile manner. Assistant will hold non-sterile bag while MD or LP inserts the sterile needle into bags for to draw up flush. Attach syringe to each needleless connector and flush each lumen of the catheter with heparinized saline. Do a safety pause prior to the start.
Which means that after you connect Marwa, which means this means that do a safety pause prior the start of the procedure, mean that once you gather your equipment, you discussed with the nurse and did your measurements, to take a pause, have a rest before you start, a few minutes. Yeah.
Prepare the umbilical cord and surrounding area diameter of 5 centimeters with antiseptic solution per departmental protocol. Allow drying for 2 minutes prior to umbilical catheter insertion. Trap the area surrounding the cord with sterile towels. Place the umbilical tie around the base of the umbilicus and tie once. Cut cord horizontally using a scalpel. Transfer supplies needed for line insertion, such as flushed catheter, forceps with and without teeth, and 2x2 goes onto the sterile field. Identify the umbilical vessel. The vein is thin-walled and close to periphery of umbilical stump. The 2 umbilical arteries are smaller, thick-walled, and will need to be dilated. For umbilical venous catheter placement, grasp cord with toothed forceps, avoiding vessels. For umbilical arterial catheter placement, the vessel must gently be dilated with the curved forceps. Adequate time spent dilating artery will increase likelihood of successful placement. Insert catheter into vessel using hands or forceps. Advance to measured position, then draw back on syringe to ensure easy blood return. Clear blood by flushing with 0.5 ml of heparinized saline solution. Obtain blood samples.
This is very important to clear because remaining blood in the lines can cause infection.
Yes. Obtain blood samples for laboratory evaluation if needed.
And here is very important, Marwa, when you take blood sample to withdraw all the contaminated water. Otherwise, if you don't draw very good the contaminated fluid, the sample's reading will be wrong. So it's very important to avoid contamination of the blood with the fluid that you're giving. So you need to draw back all the fluid and use the needle to take the sample from other ports. Yeah, go ahead.
Being careful to not introduce air into the line and the flush catheter with heparinized saline solution after removal. If unable to obtain blood return, try troubleshooting, such as a removal of catheter with reinsertion, doing a cut down, or if an umbilical vein attempt placement of a second catheter next to the first catheter, using a 3 silk suture on a small curved needle, suture the catheter to the Wharton jelly. Obtain an X-ray or babygram.
It's very important not to suture to the skin. Please remember, not to the skin. You suture to the Wharton jelly, not to the skin.
Obtain an X-ray or babygram while maintaining the sterile field to verify the position of the catheter and adjust as necessary. If the umbilical catheter is too deep, it may be withdrawn to correct position in a sterile fashion. If under sterile conditions, an umbilical catheter may be pushed in if found to be low to the correct position. But once no longer sterile, the catheter must be removed. Once the placement is confirmed, make sure to fully secure the catheter by suturing in place. Antiseptic solution should be removed from the skin using warm water or saline and goes after the procedure. Make sure to complete the procedure note in the patient's chart. The procedure note should include radiographic verification of the catheter tip, also confirm final position, and the bedside nurse. The bedside nurse will secure the umbilical catheter to the abdomen by placing a cut piece of duoderm on the abdomen next to the umbilicus. And securing the umbilical catheter in a loop over the duoderm using Tigaderm, ensuring that the catheter markings are visible. In infants with both UAC and UVC placements, each line should be secured separately, one on each side of the umbilicus. Nurse or assistant task.
No, we'll do it next by the nurse, not by you. So Madonna will do it next Thursday, inshallah.
Inshallah.
Any question? Anybody has any question? Thank you, Marwa. Thank you very much. So if you don't have a question, I will end, but we need to join again, me and you, Marwa. I will join with you just to discuss. Okay?
Okay. Thank you.
Okay, so we'll end this session and then we'll start.